Again, I'm Kelly Finan, and I'm a colorectal surgeon here. My office is over at Our Lady of the Lake, and I practice pretty much throughout most of the city. And today we're going to talk about colorectal cancer screening and prevention. Obviously, this is a topic near and dear to my heart since that's what I specialize in. And it's kind of a good topic to bring up as March is the advent of Colorectal Cancer Awareness Month. All right, so why is colorectal cancer important? Why do we need to talk about it? Well, there's 150,000 new cases diagnosed in the United States each year, and it remains the third leading cause of cancer death in the United States, with about 50,000 deaths per year attributable to colorectal cancer. When we look at mortality, this was data from 2005, you can see that cancer, and this is all cancers, still remains the second cause of death in Americans. So it's still, I mean, this is a big topic we need to talk about. And when we look at changes in death rates between 1950 and 2005, so over a 55-year span, although heart disease still remains the #1 killer, look how much progress we've made in treating that. And the same with cerebrovascular disease or stroke. But cancer, you see, our death rates really haven't changed that much over a 55-year period, meaning we still have a lot of progress we can make. And you want to know, what's the risk for you? So lifetime probability of developing colorectal cancer in a female is 1 in 19. So I mean, you think of how many, members of your family or, close friends, 1 in 19, I mean, that's pretty high odds, or that's about an 8% risk in your life of developing colorectal cancer. And this is incidence rates between 1975 and 2004. And if you look, the incidence, that means the number of new cases diagnosed each year of colorectal cancer, really hasn't changed that much. Maybe a slight decrease. And it's just third behind breast and lung cancer. And then when we look at death rates, so these are people dying, each year from colorectal cancer, it still remains the third leading cause of death, and this is just in women. You see, we have made some progress, so we are doing better at treating, as you see this decline here, but it's still the third leading cause of death from cancers. And again, when we look at last year's estimated cancer deaths, colorectal cancer accounted for 9% of the deaths, and that was in women alone. And again, the third leading cause of cancer deaths. So why am I boring with all these statistics? Well, I mean, it's astounding to me that this still remains the third leading cause of cancer, because 90% of colorectal cancers really can be prevented, and people shouldn't be dying. People shouldn't even be getting cancers if we're doing the right thing for them and getting them screened properly. So that's where I'd really like to drive the point home today. I mean, colorectal cancer is a preventable disease. It's not something that just happens overnight. And so we really need to do better with this in society. And so why is it preventable? Well, we get a precursor lesion, a polyp, that then subsequently turns into a cancer. So if we can catch the precursor lesion, cancer shouldn't develop. And they also don't occur overnight, and they don't spread quickly. These are slow-growing tumors. And so all this gives us plenty of time to catch them early. We also know a lot of genetics that are very well defined, so we know more of the high-risk populations of people that maybe need to be screened earlier. And we also know risk factors in our lifestyle that can be done to help modify our risk of developing colorectal cancer. So this is some pictures kind of whenever I'm doing a colonoscopy. And as you look, here's kind of a normal colon, and then a polyp starts to grow real slightly here, and then it gets even bigger here, and then develops into a cancer. And it takes about 10 years to go this whole sequence in an average risk person. So we have a lot of time to catch it. If we can catch the polyp and remove it here, this is us snaring a polyp off, we can prevent the colorectal cancer. And there has been studies showing that if we can detect and remove polyps, we can decrease the mortality from colorectal cancer and the incidence of it developing. So again, the natural history, you have a polyp and it takes about 10 years to grow into a cancer, and then it takes several more years to continue to grow through the depth of the bowel wall and invade lymphatics and spread to lymph nodes, and it can invade blood vessels and spread to other organs like our liver and lung. So again, this is a fairly long sequence. So when someone gets diagnosed with a colorectal cancer, it's not like it just popped up overnight. It's probably been brewing there for a while. If you develop a colorectal cancer, is it a terminal disease? Well, not if we can catch it early. So stage 1 cancer, if we can operate on those early cancers, we have a 92% 5-year survival rate. So it's still very curable if we catch them early. Now, if it's spread to other organs like the liver or lungs and making it a stage 4 cancer, you can see we have a much lower survivability at 5 years. And so we want to, if we don't catch it as a polyp, we at least want to catch it as an early cancer because it's still very treatable and curable. Okay, well, yeah, so we can go over this. So a stage 1, and I think I have a picture later in the slide, a stage 1 is where the cancer is invaded through the partial thickness of the bowel wall, okay? A stage 2 is where it's spread through the full thickness of the bowel wall and maybe even into the surrounding tissues or organs. These are all when it's just confined to the bowel wall, stage 1 and 2. Stage 3 means the tumor is spread into the lymphatics and invaded lymph nodes. And so the only way for us usually to know that is after we perform surgery, we take the lymph nodes out. And a stage 4 cancer means it's spread to other organs. And colon cancer usually spreads to liver or lungs or invades directly into another organ surrounding it. So what are the signs and symptoms to look for? Well, unfortunately, there are no symptoms in most cases. But there are some nonspecific symptoms that one can look for, and these definitely should raise kind of a red flag, like something not right's going on here. We can have blood in the stool, anemia, a change in bowel habits, and that means, kind of changing from constipated to, or a change in the caliber of your stools. If you normally had larger stools and they become pencil thin. Weight loss, a bowel obstruction, or obviously if you feel abdominal mass or pain. Unfortunately, most of these symptoms don't arise until fairly late, unless it's maybe a low rectal cancer. A lot of these symptoms, if it's in the right side of your colon, it can go unnoticed until the tumor becomes very large. So who's at risk? The average risk person would be defined as someone over the age of 50, no family or personal history of colon cancer or polyps, and who's just asymptomatic. So this is our average screening person. This is who we'd love to see. They just come in, I'm having no problems, let's go ahead and start screening, because we know that cancers start to develop more with age. High-risk people are patients, obviously, that are symptomatic, that are having a lot of those symptoms we just talked about, or have a family or personal history of not only cancers, but polyps. Because if you have a family history of someone who forms a lot of polyps, you're probably going to be one of those people who can form a lot of polyps. And there's other genetic causes, I should say, too, that we can talk about in a few minutes. Or if people have inflammatory bowel disease, there's some other medical conditions that can increase and put you more in that high-risk category. But again, 75% of patients are asymptomatic and have no family history. So just because your mom and dad never had any problems doesn't mean that you're free and clear and shouldn't get screened. There are a lot of causes to colorectal cancer, so there's not one thing you can do in life to prevent it. There's a lot of environmental factors that we know go into play. Age and time, as our bodies get older, there's just a greater chance that some cell is going to go awry and grow into a cancer. And there's also genetic susceptibilities. So again, risk factors, we just kind of talked about age. We talked about how polyps, there's a normal sequence that most cancers arise straight out of a polyp. There's genetics. There's some defined genetic syndromes we know of. There's one called familial adenomatous polyposis, which is a condition where nearly 100% of family members will develop colorectal cancer, usually by the age of 30, and that's where their colon gets lined with about thousands of polyps. There's another one that's kind of more silent that people don't talk about, and it's getting a lot more attention. It's hereditary non-polyposis colorectal cancer. And that's actually a syndrome linked with other cancers. So endometrial, ovarian, and stomach cancer are also linked in that. So when someone has a strong family history of those 5 cancers or developing cancer at a younger age, we worry about that. And then there's just risk factors. If you have a first-degree family member who's had a colorectal cancer, you're at twice the risk of developing one yourself. An environment plays a role, diet, geographic location. We know Western industrialized societies have a higher risk of cancer, and physical activity. And inflammatory bowel disease, we kind of talked about ulcerative colitis and Crohn's. I'm not going to get into those, but after about 10 years of disease activity, those individuals have an increased risk of developing colon cancer as well. So genes, I don't want to make this too scientific, but we have genes that code for cell growth, and we have genes that code for, they kind of act as like the teachers and go through and make sure that everyone's doing the right job and fix things if they're not doing the right work. And these genes can help control the cell growth, and when they become abnormal and don't get fixed, then they can grow out of control. Did you have a question?
Did you mention Crohn's disease?
I did, yeah. Absolutely, absolutely. So Crohn's disease is an inflammatory disease that can affect anyone from the mouth to the anus, and people have different activities of disease. Some people have disease limited to the small bowel, some people have disease limited to the colon, some people just have anal disease. And whenever someone has a Crohn's activity in their colon, after about 10 years, your risk of colon cancer starts going up about 1% a year. And so it's real important. Usually the recommendations are after 10 years of disease activity that we do a colonoscopy every other year at least. And if we find any abnormal cells, then we might need to talk about doing surgery because of the risk of cancer in that colon. So again, we kind of briefly touched about the genetics, but this is just kind of a pie chart. So again, just because you don't have a genetic history, 75% of colon cancers are sporadic, okay? But there are these 25% that do raise our suspicion, and if you have a family history, you have some of these genetic diseases I talked about, or inflammatory bowel disease, which is the Crohn's and ulcerative colitis, you would probably be put into a different screening category. But again, most of these aren't going to have a precursor. So how does diet affect colorectal cancer? Well, there's things, I don't know if you've heard the word carcinogens, but those are toxins that can promote cancer in our cells. And so there can be toxins in our foods that can cause damage to the cells in our colon. We think fiber may protect some of this. And fats can also cause. A lot of saturated fats can react with bile acids and form substances which will cause our cells to multiply and develop into a cancer. There's a lot of things out there that we know can be associated with diet. I like to say just healthy eating and healthy living is some of the key factors that can help decrease colon cancer. But some of the specific dietary causes of colorectal cancer, we know that diets high in red and processed meats, high in saturated fats, as well as high in alcohol consumption can all increase your risk of colorectal cancer. Okay, dietary regimens that will protect from colorectal cancer are things high in fruits and vegetables and fibers, milk, calcium, folate. So all things we should be trying to get a lot of in our diet anyway. Other risk factors that have been linked to colorectal cancer, there's obviously been a lot of studies on this. Obesity can be linked to increased risks of colorectal cancers as well as other cancers such as breast cancer. And that's due to increasing levels of estrogen that circulates from all the extra fat tissue in our body. We know that physical inactivity is actually associated with increased risk of colorectal cancer, so having regular exercise can actually decrease your risk. Diabetes is linked to it, as well as smoking. So screening for colorectal cancer. Fortunately, this isn't the way we have to go about it these days. But let's talk about that, because that's really the crux of what I want to get my point across today. All right, so screening, why is it important? Well, we can remove polyps before they turn into cancers. We kind of talked about that already. It can also allow us to find cancers earlier when they're more curable. So those stage 1, 2 cancers instead of those cancers that have spread to other organs. And it can reduce our cancer-related mortality. And there's been several studies out there. In one study, we actually saw a 1/3 decrease in mortality by implementing early screening. So the American College of Surgeons recommends for screening that at age 50, people either get a yearly fecal blood test, a sigmoidoscopy every 5 years, or a colonoscopy every 10 years. And we'll talk about these 3 tests more specifically. So fecal blood testing. This is where you get a stool sample and they test it for blood in there, okay? And if it's positive, if you see blood in the stool, you're recommended to undergo a colonoscopy. This can reduce the cancer death rates by only 10 to 30%. So it's not our best test out there, and it's not one that I actually commonly order or recommend. But if people are living in a more rural area, don't have access to some more medical care, at least this is doing something. We're trying to look. The problems with this is, again, it's only marginally sensitive. It detects only about 50% of cancers, and it's even lower for polyps. Polyps usually don't bleed, so there's usually not blood in the stool, and only advanced cancers that have an ulcer that's bleeding are usually going to put blood in our stool. And also has a poor specificity. So there's a high false positive rate. I mean, you might have hemorrhoids, a fissure, other things causing blood in your stool, or maybe you ate something that gives the test a false positive. And most positive results actually do not indicate a cancer or polyp. So you get a positive test, then you're referred to colonoscopy, and you have to wait, and that can cause a lot of anxiety in people. So I don't think this is the best test out there. Flexible sigmoidoscopy is something that's readily available in most communities, even if you're out in a rural medicine type community and don't have access to major medical centers. This is where we put a flexible camera and we can look up through the rectum and up through the colon, but we can only get about as far as here and out of the sigmoid colon. This is your descending colon. That's about the highest we can reach with a flexible sigmoidoscopy. So the pros of this is it's well tolerated. We usually just give you a few enemas, okay, and so it's not a big prep. It can be done in the office with minimal discomfort. We don't require any sedation really for it. And it can reduce cancer death rates by as high as 60%. The cons are, as we just pointed out, it only examines about 1/3 of your colon, so we're missing 2/3 of the territory, so it can miss about 40 to 50% of cancers. And a positive exam requires a full colonoscopy. So we know if you find a polyp in the left side of the colon, the chances of having a polyp or a cancer in the right side of the colon are increased. And so, again, this is one of those, if we do this test, you might be referred on for another test. So colonoscopy, this is a colonoscope, and this is some camera drivers up here, and this is a long scope that can be inserted through the rectum and the whole way up through the entire colon. So we get over here to the small bowel, and this is your appendix, okay? So we know we've reached the end when we see both of those landmarks. And this is really the gold standard test, okay? The sensitivity can be as high as 97% if someone has a good prep, because we can see almost virtually all the colonic mucosa. It can be both diagnostic and therapeutic, meaning we can see and detect polyps or cancers, and we can also remove them or biopsy them in the same process. So it's not, doing one test and then sending you for a second test. We can do it all with this one. And if it's normal, you don't have to have a repeat colonoscopy for 7 to 10 years. So it's not having to do a test every year. The risks are minimal. There's a risk of bleeding of about 0.6%, and that's usually more whenever we actually have to remove a polyp. A risk of perforation or damage to the colon wall, about 0.5%, so very rare does that occur. And that's usually actually when we're being more aggressive in trying to remove a polyp to prevent surgery. The quality of the exam is related to the quality of the prep, so you do have to be compliant the day before. I mean, if the colon's full of stool, we're not going to see anything. Some other things you might have heard about in the news, and I just mentioned this, there is a test called CT colography, and this got a lot of hype, but it really hasn't taken off yet. They developed it maybe 5-10 years ago, and this is where you undergo a CT scan to look for polyps. The problem is the sensitivity varies from 35 to 90% for lesions over a centimeter. And whenever we're doing colonoscopy, we can see little polyps less than a centimeter, and so that's good. It still requires you to do the full prep, so you're not getting out of that, you're just getting out of the procedure. And if your test is positive, if they see a polyp, they can't remove it. So this is only diagnostic, it's not therapeutic. Then you still have to go do a second prep and get a colonoscopy. But the indications, I use this occasionally if there's a reason we can't complete someone's colonoscopy, we can't get the whole way over to the right side of the colon, maybe due to scar tissue or other factors. Or if someone has a medical condition that prohibits colonoscopy, okay, they can't do the prep, they can't have sedation, maybe they have a bad pulmonary disease. This is a good test for screening for them. So it's promising, but I'd say not really ready for prime time. Well, it all depends. If there's an indication, they will, but we have to have an indication. So again, cancer screening recommendations for the average risk person beginning at age 50 are yearly fecal occult blood tests and flexible sigmoidoscopy every 5 years or a colonoscopy every 10 years. The sad truth is that most Americans are not screened. So we know all this information. We know we have a lot of means to help people and we can really prevent colorectal cancer. We're just not getting it out there to the public. People aren't adhering to this. Only about half of Americans have completed the recommended screening test. And it's new data that I just looked up at the CDC. Louisiana ranked 43rd out of 51 in the nation for compliance with colorectal cancer screening. So we have a lot of work we can do. And interestingly, Louisiana is one of the 24 states in the country that actually requires private insurance companies to pay for all colorectal cancer screening tests. So if anyone has insurance, they should not be denied for screening purposes. It's a state law. So we really can do a lot better and really need to do a lot better. So remind your primary care physician, remind your friends, remind your family when it's time for your first screening exam. And, don't be scared of a prep. A prep isn't fun. It's 3-4 hours of going to the bathroom. You have to drink 2 liters of fluid. But it sure beats having to have, cancer and having to have a major surgery for that and maybe chemotherapy and all that. So prevention is really the key. But if a cancer develops, can we still treat it? Of course. So surgery really offers the best chance for cure when that does occur. So once a cancer is diagnosed, what we do is we want to evaluate for the spread of the cancer. Okay, we do some lab work, we do some CT scans to make sure it hasn't spread to other organs. And early cancers confined to the bowel wall can be usually cured with surgery alone. and I know a lot of people have fear of ostomies. Most tumors can actually be resected and the bowel put back together at the same surgery. There's a few indications where people might have to get a bag or an ostomy, but that's rarely the case. Most people can have their bowel put back together these days. Yeah, yeah, exactly. So this is another picture of the colon. So the small bowel comes down here and drains stool into the colon, and this is called our cecum, our ascending colon, our transverse colon, our descending colon, our sigmoid colon, and our rectum. And cancer can occur anywhere throughout this. And the extent of surgery, not to get real specific, depends on where the cancer is. So if you have a cancer over here in the right colon, we take this portion of the colon out, and likewise. So what's new in surgical therapy? Now we can do a lot of surgeries laparoscopically, and that's something I have a strong interest in. And this minimizes the incisions on the abdomen. So what we do is we put a few small poke hole incisions, and we can put some instruments and a camera in and mobilize the whole colon or rectum if we need to. And then we make a small incision on the abdominal wall to take the specimen out. And so we can send that off for pathology and put the bowel back together. The benefits of doing things laparoscopically is there's a reduction in postoperative ileus, which means sleepy bowels. So people can usually start eating faster. They have less pain because they have less incisions on the abdominal wall, and so they require less pain medication. They usually get back to their regular activities faster. We have improved cosmetic results. A lot of women are worried about having big scars on their belly. And we also have less scar tissue internally, which can cause obstructions of the bowel in the future. And we also see a shortened hospital stay. So there's a lot of benefits to doing this laparoscopically whenever we need to operate on people. Again, survival, we touched on this earlier, really depends on the stage. So stage 1 cancers are the ones that have only gone partially thickness through the bowel wall, and they have a 90% 5-year survival rate. In the stage 2 that have gone through the full thickness of the bowel wall have about a 70% 5-year survival rate. When people have node-positive disease or stage 3 disease that spread to the lymph nodes, the survival decreases, and as well as distant metastasis. So some of the take-home messages I hope I've gotten across today is that colorectal cancer is preventable. So we need to initiate regular screening colonoscopy at the right times in our lives. There's things you can do. Think again, healthy living, so dietary modifications, eating a diet high in fiber, fruits and vegetables with moderate alcohol consumption, and limiting some of our saturated fats, red meats, processed meats. Regular physical activity and maintaining a healthy body weight can all help prevent this. So, here's some resources, and you guys have some handouts. If you do have more questions, the American Cancer Society and the National Cancer Institute all have nice information pages for patients. American Society of Colorectal Surgeons that I belong to also has a lot of good information out here. Here's another one, Colon Cancer Prevention, that really talks about the screening. And this is our office website, actually, Baton Rouge Colon Rectal, and we have a lot of these resources on there that can link you up. So, all right. Well, thank you guys, and hopefully we left a little time here for questions if anyone has some. We entertained a few at the beginning.
I have lactate, I'm like lactate intolerant.
Mm-hmm.
And I eat certain things like cheese or something. A couple hours later, like eat that maybe. Does that have anything to do with possibly something to do with the colon?
Yeah. I mean, if you're lactate intolerant, it means that your body's not breaking down the milk and absorbing it, and so then it can lead to, when you get the milk, it fastly traverses your small bowel and hits your colon, and you probably get diarrhea. Now, there's pills out there that can help bind that, so you can eat that. I don't think lactate intolerance doesn't increase your risk of cancer. No, it shouldn't increase your risk.
But your sister having had polyps,
Yeah. So some more specific things. I hate to belabor the point, but if you have a family member that had polyps in their 50s, you actually should start your screening 10 years earlier. So you might need to start your screening. Yeah, if she had polyps at age 50, it's an indication to have a screening endoscopy done at 40. So it's not just the cancer, but it's the polyps as well. There's actually some new data out there which hasn't changed all society's recommendations, but African Americans we know actually develop cancers, we think, at a little bit earlier age, and whenever they're diagnosed, they're usually diagnosed with more advanced stage cancers. And so one of the societies has actually changed the recommendations this past year that African Americans should start colorectal cancer screening at age 45. And so I'm assuming that other societies are going to start changing that. I mean, I think across the board, if you read most recommendations, it'll stay 50, but it might be reason to start increasing our screening cancer.
Because I've met several people and had a friend that was in her 40s, a black woman who got colon cancer.
Yeah, so,
So I think screening that might be a great one.
yeah.
And again, discuss your cancers out there. Something you want to have one done. Is it
Yeah, yeah. It's, you know, the only and if your insurance doesn't require a referral, I mean, you're welcome to call me or, you know, any colorectal surgeons do endoscopy, gastroenterologists do endoscopy. So, you know, some insurances don't require a referral. That kind of goes back to your insurance carrier. But your primary care doctor is usually the one that can help you get you linked up right away.
Because that's my concern. I don't have any belief in anything, but it's the idea that every time I eat, like, you know, fettuccine with cheese sauce on it, I know I'm going to pay for it later. And I
Yeah.
think that has something.
That doesn't increase your risk, but your family risk could.
I'm
So,
assuming that's what it is.
yeah. Yeah. But there's medications that can treat that. You shouldn't have to live with that. Okay. Does anyone else have any questions?
Yeah, why aren't there more people in this room?
I think they're all in line right now getting other screening.
I really think that a lot of people avoid this issue, and I don't know how it can get promoted more.
Yeah. Well, we're trying.
I mean, look at mammography. For a long time, people were dying of breast cancer, and nobody was saying anything. And the federal government got involved, and
Yep.
they made it federally regulated, and then it was promoted, and we did walks for it and everything else, because it affected a lot of people, men and women.
Yep.
Most people don't know that. But there needs
Same with cervical cancer. Everyone gets their pap smears. I think there's a negative connotation on having to do a bowel prep, about talking about your colon, and I think we just need to get over that. We need to get over it.
Even on mine is the fear of knowing it. I had a sigmoidoscopy. I had that done before, and it was so painful the way the doctor did it. I thought I'll never want to go back to the doctor for something like that because they barely sedate you.
Well, for the colonoscopies, we usually sedate people pretty good. They're kind of amnestic. They don't know what's going on.
Fear of not knowing, is that going to hurt me? I mean, that's painful.
Yeah, most people don't suffer any pain because we do give sedation medicines when you get it.
Where I'm saying a lot of people don't want to talk about it because they're actually on a trip with 6 people in the van, my personal friends and a group of volunteers I was with. I said, okay, while I got everybody here, I want to tell you to have your colonoscopy because I know everyone in here is older than 50. And they were all like, Liz. I said, okay, if you don't talk about it, if you don't ever mention it, if you just ignore it, guess what? It doesn't go away.
Well, that's right, and that's good. I'm glad. Thank you.
Friends to have it.
Well, thank you all very much.